Hello, everyone. My name is Abygahle Stumpf, and this is my presentation, Non-Apparent Disabilities, Invisible Even to Medical Professionals. So, just a little bit of basic background information about me. I am currently in my senior year and am a psychology major and an accessibility studies minor. It is also important for people to know that I myself have non-apparent disabilities and that they have inspired me to spread awareness about the importance of removing ableism from healthcare and to encourage medical professionals to be more conscious of how they interact with disabled patients. This project is an autoethnography, meaning that it is academic research that is based on my own personal experiences. My project focuses on people with non-apparent disabilities and their experiences with medical ableism. People with non-apparent disabilities experience both common forms of ableism and unique forms of ableism in which they are not believed or their disability is undermined. People with non-apparent disabilities often have inequitable experiences with medical professionals. After experiencing medical ableism myself, I found that doctors don't respond positively when they feel they don't have a solution to what they deem a problem: disability. Medical professionals have a responsibility of providing compassionate, equitable care to all patients, not just those with obvious ailments or disabilities. While anyone can gain information from my project, my main goal is to educate medical professionals. I want this project to help promote positive interactions and a healthier attitude when medical professionals interact with people with non-apparent disabilities. Medical professionals don't always consider the barriers that people with disabilities experience just getting to the doctor's office. For one, not everyone can drive, has access to a car, or has access to public transportation. Over 500,000 people with disabilities can't leave their homes because of transportation barriers. Once at the doctor's office, wheelchairs aren't made readily available for use for people who are not consistent wheelchair users but may have mobility needs. After visit summaries are not always intuitive and don't encompass the full scope of the visit. Doctors must ensure that the information they are communicating to their patients is understandable and accessible so that the patients can refer to the information later. One thing that they might benefit from is utilizing the POUR principles, which is a universal design of language. So, you've heard me use the term non-apparent disabilities quite a bit already, but what are they exactly? Non-apparent disabilities is the term that the nonprofit organization Disability In opts to use. Their reasoning for using this term over others like invisible disabilities or hidden disabilities is that it doesn't imply any negative connotation like others might. Although the terms themselves are different, non-apparent disabilities and invisible disabilities are synonymous, and so they share definitions. Some people choose to use the term invisible disabilities, and others prefer to use non-apparent disabilities. Both terms are completely valid, and it's up to personal preference which one you use. The founder and president of the Invisible Disabilities Foundation, Wayne Connell, defines invisible disabilities as physical, mental, or neurological conditions that is not visible from the outside, yet can limit or challenge a person's movements, senses, or activities. There's a lot of research behind this topic that's important to consider. For one, DeVries McClintock and their colleagues interviewed people to gain a better understanding of the healthcare experiences of both non-disabled and disabled patients alike. They found that people with disabilities reported being more dissatisfied with their medical care and had experiences with medical professionals that left them feeling invisible, and that they were treated as a disease or a body part rather than a human being. Another thing to consider when exploring not just medical ableism, but ableism in general, is the models of disability. The medical model of disability is the one that informs the medical community, and that's most widely accepted. There are unfortunately downsides to it, though. While it does help people as it inspires innovation and the discovery of new treatments, it also alienates the disability community as a whole. Many critics would argue that the medical model deprives disabled people of full involvement in and contribution to society. The social model of disability is one that many members of the disability community prefer because instead of viewing disability as something that needs to be cured, the social model calls attention to systemic barriers and names those as the true cause of impairment. Unfortunately, though, the social model can be alienating to many people with non-apparent disabilities, such as chronic pain to name one, as the social model so strongly disowns individual and medical approaches that it risks implying that impairment isn't a problem, which unfortunately undermines the experience of many disabled people. My research affirmed my own experiences and highlighted a need for more compassionate, informed interactions and care that affirms people with non-apparent disabilities. My story, though disheartening, has power. By telling my story, this project focuses on calling attention to the ways in which many medical professionals fall short in their interactions with people with non-apparent disabilities. As mentioned earlier, this project is an autoethnography, meaning that it will be utilizing my own personal experiences in order to explore larger social and cultural phenomena. As a person with non-apparent disabilities, my experiences act as the foundation for this project. I used my own personal accounts, my parents' memories of those accounts as they were present at all of my doctor's appointments, and available after visit summaries as the main sources for this. My data was collected through writing out my experiences, corroborating the details with my parents, and through reading available after visit summaries. One thing that still replays in my mind was a comment my doctor made to my mother when we were discussing how much I was struggling with my cyclic vomiting and mobility. Well, she looks healthy enough, implying that what I was going through must not have been that severe. What the doctor didn't know was that me maintaining my weight was the result of medication side effects and what we now know is polycystic ovarian syndrome. Doctors often did not consider the weight of their words when interacting with me. They would question my honesty when discussing my symptoms and often assumed I was exaggerating. My parents and I left doctor's appointments feeling as though my chronic health conditions, though debilitating for me, were not serious enough and were not well known enough for many doctors to take interest in. We were left with no guidance and seemingly no compassion. Doctors were continuously attempting to find medications that would treat or cure my different illnesses, with most of them failing outright or having little effect. As a result, I became very frustrated and tired with being on medications and treatments that I believed never really did enough. These continuous interactions had a lot of negative outcomes, a lot of which I'm still dealing with today. I've suffered from lower self-esteem, which I'm still working on recovering. I experience heightened anxiety during doctor's appointments, and so I will delay them for as long as I can. I have a distrust of most doctors, and at one point I had an outright disdain for them. I also have an aversion to taking medication of any kind and will avoid most of them. There is only one medication that I take daily. These situations were also a trigger for my depression, which I do still have. And the most extreme effect that these interactions had on me were that they were one of the factors that led me to attempt suicide when I was 12 years old. The unfortunate reality is that my experiences are very similar to other members of the disability community, and it appears that my experience was just one in a long pattern of medical ableism. Doctors need to understand that the way in which they respond to a person with disabilities makes all the difference. Opting to assume that a patient is being dishonest, dramatic, or that they don't know their own bodies is infantilizing, demoralizing, and damaging. Negative interactions like this not only lead to inequitable care, but also deteriorates the doctor-patient relationship, as some people with non-apparent disabilities may stop seeking medical help altogether just to avoid negative interactions with doctors. My recommendations for medical professionals is that they should treat people with disabilities as people first and disability second. While there may be times where the pursuit of treatment is wanted and necessary, it shouldn't be assumed, and it shouldn't be the sole goal of the interaction. Medical professionals should avoid undermining people with non-apparent disabilities. When someone shares their experiences, believe them and don't make assumptions. Just because you may not be able to see something does not mean it's not there. And it's important that medical professionals go into these interactions with their patients recognizing that. Overall, appointments should be a means for collaboration where the person with disabilities can lead and be an active participant in their care. Time and health were both limitations that caused me to amend the scope of my project, along with the fact that I was unable to retrieve all of my medical records in time. This is an autoethnography, meaning it focuses on personal experiences, which can sometimes open the door for potential biases, though I don't believe that this infringed on the applicability of my findings. Autoethnographies are an effective way to explore power imbalances because it gives a platform for disenfranchised group members to comment on flaws within the system through professional, credible means. I would also like to take this time to thank my parents, my fiance, and my professor, Lynn Swedberg, for their support during this project, as they had to look over my research countless times. This was the only place I was planning on presenting this project, but in the future, I would love to continue to expand on this. I will be pursuing a master's degree in clinical mental health counseling and then my PsyD in either clinical or counseling psychology. I want to create a space within psychology that promotes affirming care to people with disabilities. Thank you for your time.